embraced by the needle. Addictions always originate in unhappiness, even if hidden. They are emotional anesthetics. They numb pain. The first question always is not why the addiction, but why the pain? The answer, ever the same, is scrawled with crude eloquence on the wall of my patient Anna's room at the Portland Hotel in the heart of Vancouver's downtown east side. Any place I went to, I wasn't wanted, and that bites large. The downtown east side is considered to be Canada's drug capital, with an addict population of 3,000 to 5,000 individuals. I'm a staff physician at the Portland, a nonprofit harm reduction facility where most of the clients are addicted to cocaine, to alcohol, to opiates like heroin, or to tranquilizers, or to any combination of these things. Many also suffer from mental illness, like Anna, a 32-year-old poet. Many are HIV positive or have full-blown AIDS. The methadone I prescribe for their opiate dependence does little for the emotional anguish compressed in every heartbeat of these driven souls. Methadone staves off the torment of opiate withdrawal, but, unlike heroin, it does not create a high for regular users. The essence of that high was best expressed by a 27-year-old sex trade worker. The first time I did heroin, she said, it felt like a warm, soft hug. In a phrase, she summed up the psychological and chemical cravings that make some people vulnerable to substance dependence. No drug is, in itself, addictive. Only about 8% to 15% of people who try, say, alcohol or marijuana go on to addictive use. What makes them vulnerable? Neither physiological predispositions nor individual moral failures explain drug addictions. Chemical and emotional vulnerability are the products of life experience, according to current brain research and developmental psychology. Most human brain growth occurs following birth. Physical and emotional interactions determine much of our brain development. Each brain's circuitry and chemistry reflects individual life experiences as much as inherited tendencies. For any drug to work in the brain, the nerve cells have to have receptors, sites where the drug can bind. We have opiate receptors because our brain has natural opiate-like substances called endorphins, chemicals that participate in many functions, including the regulation of pain and mood. Similarly, tranquilizers of the benzodiazepine class, such as Valium, exert their effect at the brain's natural benzodiazepine receptors. Infant rats, who get less grooming from their mothers, have fewer natural benzoreceptors in the part of the brain that controls anxiety. Brains of infant monkeys, separated from their mothers for only a few days, are measurably deficient in the key neurochemical dopamine. It is the same with human beings. Endorphins are released in the infant's brain when there are warm, non-stressed, calm interactions with the parenting figures. Endorphins, in turn, promote the growth of receptors and nerve cells and the discharge of other important brain chemicals. The fewer endorphin-enhancing experiences in infancy and early childhood, the greater the need for external sources. Hence, the greater vulnerability to addictions. Distinguishing Skid Row addicts is the extreme degree of stress they had to endure early in life. Almost all women now inhabiting Canada's addiction capital suffered sexual assaults in childhood, as did many of the males. Childhood memories of serial abandonment or severe physical and psychological abuse are common. The histories of my Portland patients tell of pain upon pain. Carl, a 36-year-old native, was banished from one foster home after another, had dishwashing liquid poured down his throat for using foul language at age 5, and was tied to a chair in a dark room to control his hyperactivity. When angry at himself, as he was recently for using cocaine, he gouges his foot with a knife as punishment. His facial expression was that of a terrorized urchin who had just broken some family law and feared draconian retribution. I reassured him I wasn't his foster parent and that he didn't owe it to me not to screw up. But what of families where there was not abuse but love, where parents did their best to provide their children with a secure, nurturing home? One also sees addictions arising in such families. The unseen factor here is the stress the parents themselves lived under, even if they did not recognize it. That stress could come from relationship problems or from outside circumstances such as economic pressure or political disruption. The most frequent source of hidden stress is the parents' own childhood histories that saddled them with emotional baggage they never became conscious of. What we are not aware of in ourselves, we pass on to our children. Stressed, anxious, or depressed parents have great difficulty initiating enough of those emotionally rewarding, endorphin-liberating interactions with their children. Later in life, such children may experience a hit of heroin, as the warm, soft hug my patient described. What they didn't get enough of before, they can now inject. Feeling alone, feeling there has never been anyone with whom to share their deepest emotions, is universal among drug addicts. That is what Anna had lamented on her wall. No matter how much love a parent has, the child does not experience being wanted unless he or she is made absolutely safe to express exactly how unhappy or angry or hate-filled he or she may at times feel. The sense of unconditional love, of being fully accepted even when most ornery, is what no addict ever experienced in childhood. Often not because the parents did not have it to give, simply because they did not know how to transmit it to the child. Addicts rarely make the connection between troubled childhood experiences and self-harming habits. They blame themselves, and that is the greatest wound of all, being cut off from their natural self-compassion. I was hit a lot, 40-year-old Wayne says, but I asked for it. Then I made some stupid decisions. And would he hit a child, no matter how much that child asked for it? Would he blame that child for stupid decisions? Wayne looks away. I don't want to talk about that crap, says this tough man who has worked on oil rigs and construction sites and served 15 years in jail for robbery. He looks away and wipes tears from his eyes. And that was an essay from Dr. Gabor Mate on his experiences practicing addiction medicine in Vancouver, BC. Our guest on the show today is also an addiction specialist. Dr. Jamie Pollock began his career in sunny Nevada as a pre-med student. In his early days, Jamie interestingly held a part-time job in the histopathology laboratory while taking a full course load to get into medical school. He finished his training and went into independent private family medicine practice in a small foothill town of Pueblo, Colorado. Pueblo, being a town where the patient demographic is nearly 50 to 60% working poor, has a high prevalence of substance use disorders ranging from alcohol to fentanyl. Jamie became dual-boarded in both family medicine and addiction medicine and became the community physician responsible for taking on some of the most difficult addiction patients. Some of his patients began using fentanyl, among other hard drugs, at the age of 13. His background in adolescent medicine gave him the ability to treat patients who the local health system simply could not handle. Dr. Jamie Pollock is a delightful man who agreed to give us an hour of his time to talk about his decades of experiences from deep in the trenches of medicine. You will enjoy this episode. Let's get into it. Welcome, Dr. Jamie Pollock. How are you doing today, sir?
Oh, I'm doing great. Thanks for having me on, Chuck.
Awesome. Now, you're family medicine and addiction medicine, right?
Correct. I'm both. I'm primarily right now at this point in my career. I've been doing addiction and then also behavioral health because we have in my area a rather shortage of um, psych providers. So I kind of ended up inheriting that as well. But I also worked for the state hospital for a few years. So
Okay. How did you choose those specialties?
That's a very good question. I even asked my chief medical officer one time, and he said I didn't. They chose me. And so I guess it's just something that I kind of dove into. The addiction part was actually around the start of what we call the opiate crisis. I mean, I was doing general family medicine for a number of years before that occurred. So in 2013, I was like, well, I'm just going to go ahead and get my X license, which you don't need now. And so I did. And consequently, I also brought counselors on. I designed a system to where we had behavioral health, support, not just medications. And I was one of the first 400 doctors in the US to be able to see up to 275 people on Suboxone as a result. And and as I mentioned, I've also became a member of the Society of Addiction Medicine and was selected as a SAMHSA, substance abuse and mental health technical advisor. So with that, I haven't done much with that, but I try to help people when I can that are in other programs or trying to start up other things. Like I help with the Harm Reduction Center here locally as well.
I see. So, so basically, there was a high demand for it. There was a need, and you filled that need based upon the requests of your hospital leadership.
Well, actually, so I was in private practice, and this was around, say, 2012, 2013. We started to see such an influx of heroin use, especially within my location. And we only had about one or two MAT providers. And I had already been asked prior when I was working for the state hospital to help transition the DOC off of narcotics and get my X license. I just never did. And then so finally, once I saw the opiate issue ramp up, I said, I think I better go ahead and start doing this. And then it was just a storm. I mean, I was one of three providers and I was just inundated. And because I was family trained, I got pediatrics and, obstetrics intermixed into that, even though I wasn't delivering babies. But if they had an addiction, they were sending them to me to monitor that as well because of the family medicine portion.
I see. So from the get-go, you were a private practice.
Yes, yes. I was a private practice provider. I did do a stint as a hospitalist for a few years while my wife was going through chemotherapy for breast cancer, and that was just more ideal for timing and not having office things and it worked, for that time being. But also for those that are thinking about hospital medicine, I would say it's it's a great way to augment your knowledge base and your skill set, especially if you're looking to have both an outside practice. I would encourage anybody to do a little bit of hospital medicine.
Okay. I think that's wise advice. But I mean, hospital medicine, internal medicine is essentially the foundation of everything that we do. With the sickest patients in the city. Um,
And
Go ahead.
exactly. No, and that's the point is that when in the acuity of the patients that we see today has gone up substantially even in the, 2 decades or more that I've been practicing. Um, and so I think it's important and it gives you better confidence as an outpatient to decide, hey, is this a person that's going to crash? Do I need to put them in or send them in? And I really think that that just helps you.
Okay. Do you mind if I ask what general part of the country you're located in?
Oh no, I'm in Pueblo, Southern Colorado.
Oh, okay. I'm familiar with that area. I've driven through there several times.
Yeah, actually, I went to the University of Colorado School of Medicine, and did more, rotations throughout the area. But I ended up doing multiple rotations, even more south of here, in a rural location called Walsenburg. And it really got, made me think this is really neat. You kind of get to do everything because you're out in the middle of nowhere. I mean, even though Pueblo's not out in the middle of nowhere, but you get to do more. And especially back then, you were doing a lot more than you do now.
It is a nice little town. I actually stopped there. I had a broken windshield wiper in January. I was going up and I was in a storm. I actually stopped there and it stopped at the hospital. What's the name of that place?
Well, there's two. There's Parkview, and then there's the new one, which is Spirit, Common Spirit, which used to be St. Mary Corwin.
Okay.
But both are bigger institutions now, which kind of segue into the things we've talked, had questions about. Both are bigger institutions, as Parkview got bought out by University of Colorado, and Common Spirit, or Sisters of Charity, gave away or sold to Common Spirit. So,
Okay. So did you feel like you had sufficient autonomy and independence to practice the way that was best for your patient mix? Or did that change over the decades?
oh man, it's definitely changed. Some good, some bad. I think that most of it right now hinges on, kind of the pain that we're seeing with this. I don't know what you want to call it, with medicine and insurance denials and prior authorizations and whatnot. I think that hinges or interferes with the autonomy. And I'll give you a perfect I won't name me ordering a peripheral smear on a leukocytosis, high white blood cell count, and them saying, well, our computer doesn't seem to think that it's necessary. So I sent her off for flow cytometry at the local hospital and end up having, a leukemia. So that's a direct example of a lab interfering, right? Removing autonomy or getting in between the patient and the doctor's relationship.
Wow, that's really unfortunate.
I mean, it really was, and it upset me considerably. I mean, that they would even interfere in the order process, because that's the practice of medicine. Clearly, when you're trumping a physician's orders who's licensed in that state.
So what was the outcome of that case? Did she have, was it like an APML or something that they needed?
Nothing acute. Right now, it's just being monitored by ONC. They said it's smoldering, and we'll just keep an eye on it.
I see. So more like a CLL picture.
Correct, exactly.
Okay. Um, what other cases, like more in the like addiction realm, like have you experienced a loss of autonomy?
Well, I get a lot of autonomy, especially in the youngsters that I treat. I have patients that started using fentanyl at 13 years old. Some of them carry Glocks and are going through, youth corrections, and that's how I get them, or I get them from youth, probation or parole. And usually it's the ones that have been through six or seven other places because they just don't have the same philosophy, I guess, and or direct, ability to help the children. Plus, having that background in family helps because of the adolescent medicine component.
I see. Yeah, so that's a very well-rounded skill set. I mean, they couldn't you really can't put a price on that. I mean,
Well,
them having access to someone with your background is a
well,
rarity.
thank you. And that's actually the biggest scarcity from what I hear that's upcoming is both, family and behavioral health. And since I've already combined them for the last, since 2013, and currently I have five counselors and that are all certified and been there, done that kind of way to help with people that are going through substance issues, as well as, I have a LPC for the regular ones that haven't.
Okay.
Because I have so many people that I'm also treating for just regular um, issues that where they maybe were thrown on something medication wise or given a diagnosis, and I'm kind of, hey, is this really what I have?
Okay. So the counselors that work in your practice, like how did you come about them, or did they seek you out like out of their training programs?
Um, Some actually I picked up out of knowing their histories and that where they were going. So my oldest one, I knew history of that person from outside, from the state facility, and they were also so they had their certification in addiction, but they were also a BSRN, which brought a lot more to the table. And then since then, as I would go around, I would find people in peer assistance and kind of get their stories, because I find that most people in addiction, you need to have a counselor. And I know people may not like this, but I find the most effective counselors in addiction are the ones that have been through it.
That makes total sense. I mean, I remember doing rotations in the mental health ward. I actually did 6 months of a psych residency before I switched.
Nice.
And I remember, uh, like, I don't think you can replicate the level of pain that somebody who's been addicted to hard drugs has gone through, because it's like their life experience up until the point where they start using. I just don't know how you would ever replicate that level of suffering um, in like a training program. So
It's difficult. And I think the biggest part is that people don't realize how much the person that's stuck beats themselves up. I try to run a very positive centric type program to where it's very, you're going to do better, you're going to do, there's no negativity even if there's relapse. I'm not there to berate them, I'm there to help them. And you're right, there's nothing in a vacuum. These are things that have happened over, this is my choice of treatment, not my choice of I just want to get happy with this.
yeah, it's a kind of like a wave of masking a very deep pain uh, that just stems from very troubling life circumstances. Um,
Well, like I said, starting at 13. I mean, a lot of people don't want to hear that, and I'll get things like they don't believe it, but I'm not gonna. I have the receipts, but I'm not pulling receipts out for young kids,
yeah.
especially since I'm a CFR 42, which means gives them federal protections on that issue. Um, but the
So
problem that
what's CFR 42?
so that's actually the revised statute that says that those mental health informations are not that is not like a regular HIPAA thing, meaning that I have to know where that information's going. You just don't sign off and get it automatically. And it also gives protections against too many prying. So if employers want to know and they need to get an FMLA form, all I have to do is put that on there,
Okay.
because it's essentially not allowed information. It even has to be subpoenaed actually to be used in court.
Wow. Okay, so for let's take some of your most vulnerable patient population. So adolescents from really rough backgrounds that are using hard drugs. Um, you are still trying to run an independent practice. So where does the reimbursement come for those types of visits? Is it from the state?
I have very mixed. I mean, and that's right now changing considerably since Medicaid is getting less. In my particular area, we have a demographic that's mostly working poor. Um, and there was a large Medicaid population, and I chose originally to help those in that population. There's other facilities in our area that also do similar, but as a private practitioner, I found that to be the most rewarding for me. I wasn't looking for the financial big money reward, if that makes sense.
Okay.
Um, but I do have a mixed base now. I mean, I'm credentialed with a lot of people, both in behavioral and as primary. So I have to put on two different hats sometimes.
I
But as far as the reimbursement, I mean, I continue to practice where I'm comfortable. I'm not killing it like I was when I was 15 years ago, when I was wanting to work every minute of the day. But at this age, I'm 54. I'm just trying to pace myself so I can do it another 20 years.
I see. Would you say that so have you been approached by any of the health systems for like a practice purchase? And if yes, like how did you respond?
Not yet. No, I have not. And I would say probably because most of the time I'm the one that they're referring patients that they don't know what to do with. So I think I'm kept around to fill a void that's more of the patient population that are more difficult for them to handle. Not fitting in. I mean, because a lot of times when you go into a big health center, it's, can you fit into this neat algorithm? And if you can't, or if you're somewhat non-compliant, or you've had a history of substance use, a lot of people treat you differently. And so I end up being out in that area of where they feel those people are, maybe not something they want in their cohort.
Okay. Okay. So, like, you mentioned that the demographic in your town is more of the working poor.
Correct.
So, like, what percentage would you say? I mean, are we talking like 30%, 50%?
Oh no,
Like, I mean,
60, easy 60 or higher.
oh man.
Um,
Okay.
Especially when you combine indigent. We have large federal health centers here that take a majority of those patients. But again, that's where it's, oh, clear cut algorithmic medicine. I can do it. Whoops! Now we have too much complexity. Let's kick it over to Jamie.
Oh, I see. I see.
I mean, for instance, like I just got one that, so 40-year-old female that started when she was 13 abusing alcohol, is also having an issue with opiates, was seeing another provider, nurse practitioner, not anything against that, just saying that's what it is.
Yeah.
But it was still using a half a pint of alcohol a day, and has a FiberSure scan that shows that she's got, grade 3 liver disease, or stage 3. And so at 40, that was my new patient Wednesday that I had to figure out, okay, what am I going to do with her? She just used fentanyl and oxy this morning. She drank a half a pint last night, you know, and she's got all these other medications on board, and she's got stage 3 liver disease. So obviously, I send people straight to detox to start with a clean slate, as well as medical monitoring in that particular type of setting. But that's kind of a quick snapshot of complexity that I can get. You can also add people like that and add diabetes, hypertension, anything. It's very mixed and but that's kind of my gig. I like the complications, not for the patient, but for my own interest in medicine.
Well, yeah, right. That's what hones your skills. I mean, that's important. Like, you don't want all the easy patients. You
No.
dealing with the. I mean, I mean, it's the same in my business as a surgical pathologist. I kind of need to be in a big city where people like this individual is getting liver biopsied, and it's sent down to me. That's really the joy of practicing medicine, is dealing with the complex issues.
Well, and funny enough, I was actually, so before, as an undergraduate, I worked for a tissue and organ bank.
Oh, really?
So yeah, on call the whole bit while I still carried a full load undergrad.
Wow.
Yeah. And I'd be on call. I'd be up all night and still go to class, but it was the best experience because I think it prepared me the most for medical school. So, after that, I actually thought I was going to go into pathology, and did a couple of mentorships while I was in my first couple of years in pediatric pathology.
Oh, really?
Uh, yeah, because I actually loved doing histology, and I loved grossing in, and I taught as a TA micro as an undergrad. So it kind of was starting to fill in, and then I started getting around patients more, and I remember having an attending, he goes, I know you want to do pathology, but you're just so good with patients.
That is so interesting. So, was that also in Colorado where you started your training?
No, 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 no. I was born and raised in Las Vegas,
Oh, I see.
Nevada.
Okay.
And
So
Kate,
that's
were
where
you and I?
you were a pre-med doing these courses and then having this side job.
Correct. I was at UNLV. Correct.
Okay. So you start out with an interest in histology, pediatric pathology. Your mentors are commending you for your bedside demeanor, and you ultimately switched into patient-facing field.
I did. I also did 2 surgical sub-Is because that was also part of that kind of, well, I was on the transplant, you know, area, so why not? That's actually how I got accepted. I was accepted to more than one med school, and funny enough, the guy that interviewed me was the anesthesiologist on one recovery.
Oh, really?
And
That's a,
he looked at me, he looked up and he said, "What are you doing here?" And I said, "Remember, I told you what I did." He goes, "Well, I guess you're going to get admitted, get accepted then."
like it's one thing that is interesting, and I'll just share this with you of like kind of slowly starting this podcast, interviewing people such as yourself, is that it's amazing how the overlapping stories. I mean, I actually had the exact opposite career trajectory as you for different reasons. I started patient facing, and then I had a mentor in pathology, and I kind of shifted, but it overlapped with some of the changes that we've talked about on the timeline on X, the changes in medicine. It it just that so one of the big reasons that I switched away from family medicine and like patient and mental health in general is that I didn't like the direction that uh, basically how your time is valued. Like for example, I'm curious like how you deal with this. Basically people devaluing the value, devaluing the history and physical exam, which is the cornerstone of medicine. And that just didn't sit right with me. And the increasing over reliance on non physicians, where the training gap is so vastly different that it's unethical. That just didn't sit right with me. So how do you kind of like deal with that and conceptualize that? I know you're at a different phase of your career. Um, yeah, I don't know. What was your response to that? In why?
Well, I think that it comes back, you know, from a retrospective view after being doing this for a while. It's because the payers that be the way that it's set up, they don't value thinking. They value procedure. And when you look at the way payments are structured um, through RVUs, etc., those are all mostly specialists that sit at the table that do procedures, and hence the CPT issues. I think that's primarily where you see it. You can do or see 12 different medical issues at one visit in a complicated patient. Even let's take internal medicine, and they don't really give you back the same amount as if you're doing an appendectomy, right? Even though the risks are high, you may be giving a wrong medication, you could have an interaction, the patient may, I mean, there's just so much variable, but the bottom line is that they don't reimburse for thought. They teach you to think, maybe, hopefully, but
Yeah.
but they don't pay you for it.
That's correct. So, which leads me to the next kind of concept of the future of this payment system. So, obviously, the consumer is dissatisfied with our current system. The physicians are dissatisfied with it. It's on its last legs. It may take a lifetime before it totally fizzles out. But you're already starting to see uh, alternative forms of payment. Um, so direct care, and also in terms of catastrophic insurance, there was a company called Crowd Health based in Boston that is basically flipping the current model on its head. So basically, people pay between $80 a month and $140 a month, depending on their needs, and they have basically a pool of 10,000 patients that that pay into this pot, and then the company negotiates directly with physicians and pays physicians cash for either visits or procedures that need to be done, or in the case of hospitalizations, they negotiate a rate directly with the hospital service. So does that model seem viable to you long term, like with your current patient mix?
I think it's a honestly, I think it's an inevitability. I think that the grift of I'm sorry, but if you're a primary insurance, your fiduciary responsibility is to your shareholder, not your patients. And that's a really sad reality. So what I do see is a lot of patients that are getting denied, going and thinking about doing just what you're talking about, a catastrophic type backup, but then paying the regular day to day, and they're finding that it's actually a greater cost savings for them to be able to do that. And I think a lot of it comes from the fear of thinking, oh my gosh, I have to have this because I was told I have to have this insurance. And when they get it and it comes out of your paycheck from your employer, and then all of a sudden you have a $5,000 deductible, you just never get any treatment because it's just too expensive. But then if you taught them, hey, this is how it would work if you just kept that money and paid cash, or sent it to like what you're talking about, the crowd health, then that would definitely, to me, that's the future. Primarily because the insurance market has taken away so much in profit that most people, I think, are now getting aware of that.
Yeah. I mean, that's kind of what I see happening. We're in the early stages, of course. So let's get a little bit more tactical on that. So you are a small business owner. You have counselors on your payroll. Um, do they currently have conventional health insurance through you as an employer?
No, they don't. They don't. And in I mean, we're a small practice, so that would be cost prohibitive in our area, but they do end up picking up stuff similar to what we just mentioned. Um, and the counselors have actually done fairly well enough to where some of them have, well, a few of them have actually spouses that already have insurance. Excuse me, so I didn't have to
Okay.
pick that up.
Okay.
But yeah, I and everybody knows our main directive at our clinic isn't about money, it's about quality outcomes of patients. And I know that a lot of people are going in and saying, "Oh, I want to go to medicine. I want to have a comfortable living." You will, but you can also decide how much comfort and how much quality you want to give.
Yeah, that's true. I mean, people are on a spectrum with how motivated they are with money. And I agree with that. There's basically a threshold to where an incremental, increase in your salary doesn't necessarily improve your intellectual satisfaction, your work-life satisfaction. And everyone's threshold is different, but the sooner you can have that self-awareness, generally the happier you're going to be in this line of work.
Oh, most definitely. And I don't think, and what's bad is that most residencies do not prepare you to be able to do private practice. It's almost discouraged, I think, at this point.
Oh yeah, like
But
absolutely. I mean, that's something that so I'd like your opinion on this. So, given what we just talked about, with differing motivations of the financial component of this career, one thing that I saw happening in my residency, less so in med school, but more when I got to residency at a academic facility, um, was like this vilification of the business side, like as if it's money is beneath you as an intellectual, like that we can't be bothered with that dumb money making side of it. Now it's just like, do you realize that all of these administrators that employ you as academic doctors, they're making money off of you and they're laughing their way to the bank. They're looking for ways to commodify you even
100%.
more. So how do you respond to that kind of psychological construct that is being fed to trainees?
That is a very it's garbage. It really is. I think that what we need to do is restructure a lot of medical education. I've seen some of the recommendations for it. I don't know if making it shorter is better. I don't think that's the way. But I do think that having an administrator, a hospital administrator that's medically trained, is a much better outcome than one that's not. Otherwise, we get into widget factories. And with that, it's what's production? Are you covering your salary? If not, I mean, I've seen many young doctors that came in with great sign-ons, and they got a yearly. And then all of a sudden, administration comes in and says, "Hey, you just didn't really cover what we pay you, so you're either going to have to get less or move on." And I don't know if a lot of new med people understand that once you get out, those work restrictions and things like that are not going to matter.
They don't matter. It's a lie. It's a lie. They seduce you in there with this fantasy of, oh, come work for our health system. You're going to have work-life balance. It's like, no, 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 no. That's not how it works. How it really works is that you might have like a cushy life for about 6 months or so, maybe more
Exactly.
if you're lucky, while the department is fully staffed. But what's going to happen is that eventually, people that have been there about 5 years get increasingly disgruntled with an array of issues. Some could be work volume, others could be the interface with the administration or loss of autonomy or whatever, or even personal reasons, family reasons they have to leave. So now you're short staffed, right? You may have had 10 people, now you're down to 7 or 6. And you have no autonomy over the hiring process. So you know what your workload is. Now you can't take vacation. You're covering extra call, extra, in my case, it's frozen section call or whatever, laboratory issues. And you have no autonomy over bringing in a new person, nor do you have any decision making over the evaluation of that new person. Like, so seeking someone who's competent in the area that you really need. It could be liver pathology or whatever.
Oh, that most definitely. And I think that that's important to be able to have those. I mean, as a physician, you have to have autonomy. I mean,
Yeah.
that's just part of it. And if you're getting, this is not medically indicated, or we need to cut staff, or whatever, because it's going to increase profit margins. And I think that goes back to the same thing like we were talking before with health insurance. There's only so much maximizing they're going to get before the system crumbles, and that's where we're at right now, is watching the system crumble. But as far as people coming out, I wish they would go back to the way it was when I was younger. And, you worked hard. You worked straight through. There was no work restriction as far as hours, and you were tired for days.
Yeah. No, I think so. That concept right there is what I hope to be kind of one of the core themes of this audio show, is to just keep re-emphasizing these points, because everything that we've talked about thus far, and I think some of the people that you and I both kind of mutually follow, yeah, as physicians on X, have spoke of the exact same concepts. And so, since it's not being taught in medical school and at pre-med or in residency, well, more doctors need to start podcasts and start talking about the realities of life in the trenches and the changes that young people need to be prepared for, moving forward in this business.
Well, and what the percentages that are graduating med school and not actually going into patient care is astounding right now.
Yeah,
Uh,
can you elaborate on that?
I don't really, I think it's because they're finding that is more monotonous and not as rewarding as just going to work for a cushy grant research job. Does that make sense?
Nice.
I, I mean, that's a guess. I don't know the exact reasonings, but what I can say is that, um, I would not take patient care out. I mean, that's the whole point to me to be a doctor is to do patient. I mean, I went with many MD PhDs, and they go out and they do their research, but I still think it's important to be able to touch people, to see what it's like. You know,
Yeah,
it's just
I,
one.
I agree. That was like, that's basically the reason that we go into this line of work. I mean, unless from the get-go, you start out as an MD, PhD, and you have a research leaning, or you've done research your entire life. I've seen physicians like that go into startups, or go into other lines of work, but it's not. It's something that they kind of had a inkling for from day one. But the vast majority of us just really enjoy the clinical aspect of medicine. Um, I mean, I don't want to retire. I like what I do on a daily basis. Um,
No, and that's part of it. I mean, this I used to love, like I said, I loved scope work, and deciding whether something is invasive, non-invasive, is it, speculated or whatever you're looking at as a frozen, I think is awesome and it's very needed. And for those that are considering that, I would still consider pathology as a career choice if I had to go back. Not because I don't like patients, but because I like the scientific process.
Yeah, it's just one of those things. I think that the journey of being a physician is also one of just like self-discovery. I mean, like any career, like you're assessing it's like a series of sprints, like you're grinding for a period, you get through one phase, and then you kind of have a refractory period where you're like, okay, how do I want the next 5 years to go? Um, and um, the pros and cons to pathology as well. I mean, I guess the downside is that you kind of have to go out of your way to be visible. You know what I'm saying? Like you got to get on committees. You got to talk to people. You got to build relationships with your surgeons, with your family docs, I mean, essentially anybody who's sending you specimens.
100%. Yep.
And because it's like the world runs on relationships, and medicine is no different. You're gonna like the reality is that my oncologists who talk to me on a regular basis and who have my cell phone number. I mean, they get faster results. They get prelim. I will call them when there's an issue that doesn't quite make sense. That and ultimately their patients get better, faster results. I'm sorry, that's just the way it is. And health systems that, so you have the same problem of corporatization and pathology, right? Like you have these large corporate labs, you have these kind of big HCA type corporations that
Mhm.
want to kind of commodify what we do. But after a few months of working with those organizations, the oncologists, universally come back to us and they say, well, we don't like the service we're getting, right? Because uh, a corporate worker is not going to answer their phone, at 6 o'clock in the evening. They're not going to answer a text. They're not going to get back to you, even though they're on vacation, camping in Colorado or whatnot, which actually happened to us. In northern New Mexico, Colorado. I was like out with my family, and I was like happy to field a phone call from one of our clients. But anyways, so I had highlighted a couple of some of your older comments and posts on X that
Uh-huh.
that I knew nothing about. So one of them is from let's see here. This is from June. You're commenting on a post, and it says cadence-aware predictive models for environmental and immunization collapse, a framework for NIH funding and policy reform. So, can you describe like this abstract? Seven,
I
should I
can.
say? Yeah.
So actually, that's just that 72 comes from a standard, susceptibility, infection, uh, population style of epidemiology. But what I had always wondered was how do we come up with some way to account for the cumulative burden? Everybody looks at one issue and silos it. Is this aluminum? Is this? Is this? Everybody can silo apart. It's the sum that we can't silence. And so what I was doing is converging all of these with that theorem in order to show that if you combine a burden system with already, well, especially in this, I was explaining that with the COVID vaccines, we already had a burden system, and that within a 72-day time ramp, right, you would actually have a primed herd. And if you give a burden system an inoculation, you give more burden. And now tie that into what has not been studied, which is the interaction of electromagnetic frequency and, maybe not UV interactions with that as well into the human body. I just found it as something that is more combining all the variables versus siloing each one
I see.
as an end result. And the reason is to combine not just one, but two. And when you map out a lot of this stuff, again, this is all just ideas that I'm throwing out there to say, hey, what about this? What about that? And to me, the cumulative burden is what we're looking at for all of us. You know, we're constantly bathed in toxins, and we're constantly bathed in. I mean, I bet you see this in your pathology. You see lungs that look diseased that have never been smokers, right? Um, very, very simple concepts that we don't take into account, but that can be perturbations against the total, if that makes sense.
No, absolutely. The concept of, we just see a lot of colon cancer in younger and younger patients, and nobody really has a good answer why, whether that's an environmental factor, an aerosolized toxin, microplastics exposure to the colonic mucosa, whether that's related to the quality of, animal protein that's in this country, or some factor that's in processed food snacks in the Western world. Nobody has a good answer for this right now.
Be-
Um,
because I think that's exactly what I'm pointing out, is that we're studying each individual part in a silo and not overlapping to say, well, but 1 + 1 = 4, instead of just saying, well, we know it's not this, but we've never studied this with in relation to this. There's very weak, correct. There's very weak overlap studies with that, and we know that EMF does increase permeability across, blood, mucosal barriers, etc. Um, and it's just trying to say, well, no aluminum is good for anybody. It's not that we don't ingest it or are bathed in it, but at what point is it cumulative toxicity? And when you introduce it into a field of electromagnetic frequency, what happens?
I see. No, that's a very uh, useful kind of intellectual exercise. I'm a little rusty
And
with
that's
math. I can't say I'm Sarnor here. That's some calculus.
correct. So they're all a function of the collapse. So each one is an individual function. It's just like saying, well, if we add this, if for overall collapse, if we keep adding different things, then we can predict a window of issues to occur with a higher probability than just saying, oh, it happened. Um, and it gives a window of options. It doesn't say this is going to happen then. It just is a way of saying that could explain why we're seeing certain medical outcomes.
Okay. Yeah, and in another comment, you say, what 5-year-old me figured out? I saw the grown-ups casting a cadence, a repeating pattern designed to make people tired, confused, and quiet. They used shiny stuff, aluminum, invisible buzz, EMF, too much sun, UV, sky fog, solar storms, but never admitted they mixed them. And I realized it's not about breaking the toy, collapse, or it's about making you too sleepy to play. That's called managed docility. So I made a map of the spell, colored in the dates, and left cues. That's interesting, yeah. They hit
So
the
that
trap in the rhythm.
and that's pretty much just the basic explanation of that.
Okay.
I mean, you can even utilize that theorem to predict the probability in a bar fight, which is funny.
Oh, yeah?
So
In
it's
a Pueblo bar?
in a Pueblo bar, yeah.
That's
So
awesome. Um, all right, let me get to some of these other questions. So, so we're now in the last 3 to 5 years slowly entering artificial intelligence use in clinical practice. Most of us, are starting to use that as a research tool, or like building small tools for ourselves. How do you use it or do you use it in an addiction practice right now?
100%. I've been using it pretty interactive wise for about a year or more. Um, Obviously, a lot of insecurities with it earlier on, and I still find times when it's, when I say, hey, that's not quite right. but right now I do pretty much utilize GPT-5 and it's very good at giving me alternatives to what I'm thinking. It's kind of like the same thing when you go and you're looking at a specimen, you go, I'd like to just bounce this off somebody real quick, you know?
Oh yeah.
And and instead you go home and you didn't have that somebody to bounce it off and you go, damn, did I make that call right? Was that the right call? And I know many doctors do that. So what AI does is it says all of those options, and if that's what you did, that follows standard of care. Well, okay, I feel comfortable. I follow standard of care. Where do I see AI going? It's going to be you either use it or you don't have malpractice.
Yeah. Yeah, I can see that.
And it's going to be an augmented physician thing at first. I don't see it replacement. I see it as augmenting the ability of the provider, and it's not making them any more dumbed down and giving you alternatives. Trust me, it won't toe the line. At least mine doesn't try to toe the narrative lines on a lot of the political issues because, it will actually give me studies. But I do think that that's where we're going to be able to do, just like in that CCT model that you had with the calculus, being able to say, hey, what do all these things stacked up together give me? Right.
Right.
And then instead of having a team of researchers try to figure it out, you've got AI that can come up with a lot of good theories now. I mean, maybe not as much earlier with the hallucinations, but those are becoming much more infrequent.
Yeah,
And
and I think like, I mean, it's never going to be a. It's. I think it's just kind of. I've actually noticed a refreshing increase in my own intellectual curiosity using perplexity on a daily basis. So like, I feel like the prompts get better when you ask the model to role play. So I'll tell it if you are an experienced expert level GI surgical pathologist. Can you please give me the top 10 peer reviewed articles in the last 10 years that highlight the histologic features of pembrolizumab and related drugs' impact on the colonic mucosa? And it'll spit out like a table, of histological features, some, a bunch of references and stuff. And like, this is a topic that has been around long enough to where I already have some baseline fund of knowledge of those morphologic patterns. You know what I'm saying? So
no, that's important. That's important
it,
because that's how you know when it's right.
yeah, exactly. So, but because it's if something doesn't quite make sense, then like that's like you got to have a residency and you got to have like like real life experience to kind of calibrate your use of these models because it's intended to be an assistant, not not driving the ship. So, what is your assessment of? All right, so the counterpoint to that is the
Can I add one thing to that?
yeah, yeah.
I don't do use just one model.
Okay,
I'll interact with 5 different models just to see what cross prompting will result with.
okay,
In that order, just to see which one am I able to get more from, less from, or bad info from.
okay.
But I also play with local models on my computer, downloading them and actually playing with the weights and temperature frequency to see exactly what outcomes I can get from that too. Now, I don't recommend that for general clinical use, but for fun, it's definitely interesting.
Okay. So, one of the things that gets talked about at industry meetings for pathologists, for example, is companies like Google AI making deals with large hospital systems like HCA, and they have the exact opposite use case that we just talked about. I mean, they're not even hiding it. I mean, they're already riding the wave of the commodification of clinical practice, and they want to apply that to the commodification of histopathology, and they're scanning hundreds and hundreds of cases and different diseases, and really their goal is to do the exact opposite and just eliminate physicians altogether. And of like a dystopian world that we're heading into. So that's kind of like the extreme counterpoint. I don't know if that'll come to fruition, but what are your thoughts on that?
anything's a possibility. I mean, one of my sons that works in IT works in robotics and AI, and I can say that the advancements that we're at right now could already do that. Um, but I think what you're going to have an issue with is what's called adoption. And not just adoption from us, but adoption from the general populace that doesn't trust it completely yet either. It's a very new system, and as in anything that's new, there's always an unknown fear. I think overselling it, like a lot of places do, because they're thinking dollars and not outcomes, right? So if I make it standard of care, but I get a bad outcome, who cares? It's still standard of care. And I think that's the part that scares me.
Yeah, I would agree with that. I mean, so I'm sure that throughout the course of your career, you've been in some way involved with peer review, either through a health system or like on a hospital committee or something. At the end of the day, when things go wrong, it's personal responsibility, accountability of how do we correct this and how do we move forward. Um, I mean, I have yet. I'm still kind of early career, so correct me if I'm wrong, but I have yet to see like a major safety issue or event report that after you do a deep dive, there's not some layer of the pie or layer of that cake that is ultimately 101 level personal responsibility. I mean, and outsourcing that entirely to AI is basically going to come with uh, outcomes that are blameless. That it's like
Yeah, yeah. Who's liable?
who's accountable for this. And I mean, the advantage of being able to hold someone accountable is that that individual can be retrained, or they can have their credentials modified while they retrain on a certain area. Um, or if there's some like serious ethical problem or behavioral problems, then that person needs to be replaced. I mean, they just shouldn't be seeing patients if they have like in extreme cases, like you have bad people that somehow, you know, wriggle through the gaps in training and they wind up in practice. Um, so
Oh yeah, we've all seen them.
we've all seen them, and so that's I think that's the piece that the public doesn't see when it comes to um, medical errors, and that will become an issue with AI related errors and hallucinations. Is that at the end of the day, whether it's an order set that a surgeon uses or it's a safety lockdown for a psych patient, at the end of the day, there's some human being responsible for a piece of uh, that clinical scenario.
Well, there will be, and that's the whole point of. If they don't, then that would collapse the whole malpractice industry.
Yeah.
And I don't think they want that to go away for some reason. So,
Yeah, they
um,
don't. Yeah. They like that.
so 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 the lawyers are going to argue that point anyway. So even if AI makes a suggestion, it's going to still be the surgeon. Did you definitely agree with it? Well, I didn't agree with it, so I went this way. But they could also say, well, why didn't you agree with it? So,
Sucks. So, you have a lot of experience from the trenches. Do you think you'll ever start a Substack and, just start writing about, like stories from your decades of clinical practice?
I've thought about it. I have some, I mean, obviously, I'm sure you do too. I mean, we all have really stories that, kind of, we see so many patients, and yet there are some that just sit in your head and you're like, I need to tell people about this kind of issue, or this type of experience. But overall, I find that for those that are thinking about medicine or looking for it, to me, in my opinion, there is no better education that is there for well-roundedness, teaching you how to interact with people. I mean, all of those things, and just the experiences alone, and are so rewarding throughout the career.
Very well said, Dr. Jamie Pollock. So I want to be respectful of your time. So thanks so much for coming on Three Deeper Cuts podcast.
Oh, you are so welcome, man. Anytime. And again, it's always a pleasure. If you need me ever again, I'm here.
Sounds good. Thank you for listening to this episode of Three Deeper Cuts podcast, the lifestyle podcast for the working doctor, deep in the trenches of medicine. Today we talked to Dr. Jamie Pollock, a board-certified family medicine physician and addiction specialist. So if you like this episode, leave some comments at 3deepercuts.substack.com or on YouTube, or come find us on X at 3deepercuts_pod. Thank you for listening, and until next time, be well and stay curious. Bye-bye.